Hello, welcome everyone to the Institute of Health Economics and the network of Alberta health economists around. Very pleased that you could join with us today. I'd first like to acknowledge that here in Alberta, where we are at the Institute of Health Economics, we're on Treaty 6 land, and we'd like to acknowledge the Indigenous peoples who have lived and do live on the lands that we occupy, and certainly are committed to acknowledge Indigenous perspectives in the work that we do and the harms that were done in the past, which we're hoping to rectify and be a part of that movement moving forward. And I know a lot of people are in across the country and certainly across the province, and certainly happy to have them acknowledge the lands in which they sit on. We are today doing a very interesting initiative in which there was research that has been conducted by the North American Observatory on Health Systems. We are involved in some initial support for this, but promising initiatives for emergency department diversion and a look at insights from international approaches. And our presenters today are some good friends from Ontario, Dr. Sara Allin, and Sara is an associate professor in health policy at the University of Toronto, and she also is the director for the North American Observatory on Health Systems. And Dr. Husayn Marani is a health services researcher, and he's a research assistant with the NAOHE, North American Observatory, and conducts comparative health policy research and contributed to this work. And also Dr. Stefanie Tan, who is an assistant professor at the Institute of Health Policy Management at the Dalhousie School of Public Health, also at U of T. And so just a few housekeeping rules. You're going to be muted throughout the webinar. To submit questions during the webinar, please use the Q&A function, and we will try and get those at the end of the presentation. This will be recorded, and it'll be able to be posted for your future enjoyment and viewing and sharing with others after the event today. And so thank you for joining us, and I will now hand it over to Dr. Sara Allin and look forward to the presentation. Thanks, Sara. I think you're muted. Yeah.
Thank you, John, for the invitation to be here for our team to present this work, and thanks also for sort of spearheading this work and kicking it off a few years ago in this partnered project that we look forward to presenting. So thanks also for introducing ourselves, so we don't need to do our full intros, but we can just acknowledge the broader team. So three of us are here. Many people participated in various versions of this work, including reviewing drafts and contributing as local experts from their own jurisdictions as well. And we're grateful to the Institute of Health Economics for funding one of the rapid reviews that we're presenting, and then Healthcare Excellence Canada for the second review. So thanks again for the invitation. And the three of us will be presenting, so we'll sort of break it into thirds roughly. And we've provided an agenda to show sort of how we're going to organize our time today. And I'll present the overview of the project in terms of what brought us to this and how it evolved over the past few years. And then Husayn will present the results and methods of the rapid literature review, the sort of scholarly literature review that was conducted. And then Dr. Tan will present the results and methods of our jurisdictional review and some highlights. We will all chip in, or perhaps I might give the summary of our emerging policy recommendations from this research and end with some conclusions. But we really look forward to a Q&A and just hearing your own insights, whether it's reflecting on what we've presented or sharing your own promising practices in your jurisdictions, whether it's in a hospital level, a region, province. We know that there's a lot of promising and opportunities to learn from local initiatives as well. And we really would love to hear more and have an opportunity to hear from you today. So just by way of background, we do not need to spend too long talking about the problem space that we're all really well aware of. And some people on the line are going to be much more familiar than we are in terms of actually working in emergency departments and witnessing firsthand and dealing with the pressures that they face in terms of the overcrowding, the lengthy waits, increasingly rising demands, and all the challenges that come from complex health and social conditions that people present with. And in this context of a broader system-wide challenge in health human resource shortages and maldistribution, this is often termed the canary in the coal mine because of the emergency department is where all the system-wide challenges are seen and observed most acutely and most visibly to the public and policymakers. And Canada is not unique in facing these challenges, and often it's helpful to look around the world and look at some of the comparator countries that we often, compare Canada to and seek new ideas and inspiration. And so the, original phase of this work was conducted and published in 2023. The report is available on our website. That looked to a selection of jurisdictions that appeared to show some promise in terms of addressing this same problem within their jurisdiction, and to develop a sort of framework for how we might design policy options to address these challenges. And this work was really instrumental in the sort of second stage of the work, which was an update and expansion of the scholarly literature to kind of see if we can strengthen the evidence base for policy options and to suggest some evidence-informed policy solutions. So the objective of the second phase of the work, that's the update and that was funded by Healthcare Excellence Canada, was really to look to the literature and emerging experiences within a selection of jurisdictions to see what is known in the literature and from experiences of experts in jurisdictions, what appears to be promising, what new ideas might be learned, what are the things that we're already doing that seem to be evidence-informed, and to draw out and flesh out a new framework for the different levers that health systems managers will need to simultaneously pull in order to address this system-wide problem. And so the work, the updated work, really looked to the literature to see what has been published in this area, because we know that there's quite a lot of activity in researching and analyzing the impacts of interventions that have been introduced, whether they're within an emergency room, within a hospital, or within a health system, to address ED overcrowding and to divert lower acuity presentations to the ED. And then we also look to a selection of countries that we wanted to update sort of what we had previously done, but also to see what new learnings may be coming out in terms of where previously tried interventions have been shown to not be effective and where they may have shown some promise, and to hear from experts and what they think might be most promising in terms of lessons for other countries. So my colleagues are going to be presenting the next sections. So I'll turn it over to Husayn to walk through the methods and results of the rapid lit review, and then he can turn it over to Steph, and I'll continue to advance slides. So there might be a mismatch at some point, but I'll do my best. So over to you, Husayn.
Thanks, Sara. So as part of the first approach in this project, we undertook a rapid literature review. So we specifically looked at two databases, Medline and ProQuest, and we obviously wanted to exercise a bit of rigor. So we used the PICO framework to conduct our search. One thing I'll acknowledge in this search is that it's not wholly exhaustive of the potential search terms that we could have employed. But for the most part, it is encompassing of some of the key salient terms that we would see in the context of emergency department utilization. Terms like emergency department, urgent care. In the context of our interest group, we're looking at largely policy options, innovations around diversion and reduction of ED utilization. And we also looked specifically to our recommendations that were articulated in the first report that Sara alluded to that was conducted for the IHE, where we came up with some recommendations around how jurisdictions are diverting ED utilization. So from that, we sought to essentially validate what we saw in that previous report, things like expanded access, virtual care expansion, service consolidation, and role substitution. So any of those corresponding search terms we included in this approach. And then again, our context was very open, using terms like pivoting to primary care, the utilization of different providers like pharmacists, expanding scope of practice, and mobile applications. So if we move to our next slide, here's a brief Prisma diagram where we started off with about 453 records that were yielded in our search, and employing a variety of inclusion and exclusion criteria. We found about 27 articles that met our criteria. Another potential limitation is that we conducted this search from 2019 onward, recognizing that most of those innovations that we saw happening around recent years might still be occurring today, or might still be used today across emergency departments. But of course, we should acknowledge that there might be innovations that occurred before that have been evaluated that are not reflected in this evaluation or in this study. We also avoided specific studies. So we encouraged the search of empirical studies specifically and reviews, but we excluded things like commentaries, editorials, and interventions that were focused on temporary COVID-19 responses. If we move on to the findings, it's interesting. We actually, across these studies that were included, we found widespread geographic variation of the articles that were included. So, a lot of studies came from the US, a few studies came from Canada, and quite a few came from Europe. Interestingly, we also saw a couple from Israel, South Korea, and Turkey. So widespread geographic variation. A lot of articles were general in nature, focusing broadly on interventions that were applicable to any ED encounter, regardless of population or condition. But then others were very specific to a population or condition. So, for example, a couple focusing on low acuity children and adolescent patients, for example, children with mental health conditions. We also saw a few that were focused on COVID-19 patients specifically. And we also saw a couple that were focused very narrowly on patient populations, for example, those experiencing fractures, upper respiratory tract infections, and even residents of long-term care facilities. So when we look at the salient innovations on the next slide from the literature, building off of the recommendations from the first report, we organized these innovations across different types of service provision. So, for example, are these services or innovations representative of new service provisions, or are they enhancing existing services within EDs? And for the most part, we see the innovations falling within these two broad buckets. So they were either a net new service within the context of an emergency department, or even outside the context of an emergency department. But there were others that were enhancements to existing services within ED with the goal of diverting utilization. And so we've just, categorized or typified some of those innovations. I won't go through these in too much detail, but suffice it to say they're quite varied. For example, we see a lot of innovations in the virtual care space For example, leveraging telehealth to support screening in advance of an ED encounter, or to prevent an ED encounter where that screening would otherwise take place. We also saw a lot of innovations around leveraging health human resources. For example, specifically having a health mediator who is trained in biopsychosocial care needs, having a same-day physician within a long-term care setting to ensure that residents of long-term care are not by default going to an emergency room. We also saw a lot of innovations as far as transferring protocols are concerned. So within ED, transferring to primary care within 48 hours to minimize longer stays within the emergency department, potentially even transferring to another hospital or to the community. And we also saw interesting policy interventions emerge. For example, a hospital in South Korea, for example, in integrating a 24-hour target policy from ED. So a concerted effort built into their hospital policies to minimize long stays within the emergency department. So a lot of, building off of our previous study, a lot of compelling new insights also emerged that were not represented here, but recommendations for the future as far as the development of innovations. We are, one of those is the use of algorithms or AI to determine the level of acuity to improve triage decision making. So we haven't reflected that here, but it would be interesting to see the way in which AI has a role in diverting ED utilization in future studies. So I'll pivot now to Stefanie, who's going to talk about the rapid jurisdictional review that we conducted.
Great. Thanks for that overview about the rapid academic work. It was great to be able to supplement the previous rapid review we did with this academic literature to try and understand and assess and find the different types of ED innovations that have occurred. So I'm going to be introducing the work related to our rapid jurisdictional review. So this review sought to identify promising policy innovation. So this, as Sara mentioned, we did a piece of work for the Institute for Health Economics in 2023, and we recently updated this review by looking to identify promising innovations and announcements about new services and promising policy options for ED diversion that had been introduced since we completed that report. So in doing so, we looked to we did a targeted and iterative search of the peer-reviewed and gray literature, specifically looking at projects or new developments that had occurred since April of 2023 when we completed the previous work. And from that, we found a subset of 4 of the initial 7 jurisdictions that had pursued new policy options since that time. So when we were then able to speak with local experts to identify recent policy developments and review and validate those policy findings. So today I will be going over some of the results about the key policy initiatives and some really promising options for ED diversion in a subset of the countries we reviewed. The findings in this slide deck include results from the 2023 rapid review and updates and promising new developments in addressing issues with emergency department demand across these 4 jurisdictions. So I'll be speaking to some of the initiatives that have occurred, and I'll be speaking to each of these in more detail, but I just want to present the findings across the 4 countries just to give a bit of an overview of the types of initiatives and the and the breadth of policy options across primary, urgent, and emergency care that have developed. So in Australia, we find that there are a network of primary health networks have been introduced. So there are meso-level organizational reforms that have emerged since 2015 to change to address the organization of primary care networks in addition between the federal and state level to expand access to primary care and to urgent and emergency services. A really interesting development from Australia is broadly what they found is that they found that health system users as a whole expect to go to large hospitals in order to access urgent care. So in response to that, Australia has done quite a bit of policy experimentation related to urgent care clinics and for virtual emergency departments. So in Australia at the moment, there have been a huge effort since 2023 to establish new federal urgent care clinics. So there have been 58 new ones established since 2023. Some of these are new provision. Some of these have been achieved through additional contracts to existing primary care or walk-in clinics or existing urgent care clinics. But the intention of this is to provide new options for individuals attending with acute, unplanned, but not life-threatening health medical issues. And interestingly, across the state of Victoria during the COVID pandemic, they began to experiment with the introduction of virtual emergency departments. It began in the that has gradually been rolled out across the state of Victoria, and will be expanded in New South Wales and South Australia. So these virtual emergency departments have been a really interesting way of having individuals either approach by telephone or by computer to begin a triage system that will then divert them to the most appropriate avenue of care. And it was said to dramatically reduce the number of admissions for acute ailments that could be addressed in primary or community care. Next slide. All right. In England, we found that there has been a wide range of new policy initiatives to address and alleviate pressure on emergency department as a whole over the last 10 years, specifically. So in the previous review, we found that the NHS long-term plan included a strand of work about urgent and emergency care services to increase capacity and to grow the workforce. And we found that these initiatives, there were three main categories that we found. One of them was that there was the new organizations. So when we did our previous slide overview, we mentioned that a lot of the different countries, all the countries in the subset have experimented with new types of meso-level reorganization, mostly in the regional level, to improve the coordination and coordinated and collaborative care related to integrated models of care. And as part of that, in England, they have introduced sustainability and transformation plans in 16 of the 51 larger areas, which focused on reducing avoidable conveyance to emergency department by increasing paramedic training so that paramedics who are called out to specifically to long-term care homes or for crises related to mental health have specialty training to either take care of the call, the reason for the call on location, or to refer those seeking help to appropriate mental health specialists rather than being brought to an emergency department, as would be the first call of port of call in the normal under traditional circumstances. We also found that there is a real focus on improving community-based services, particularly in primary care, rather than just a focus on diversion. So there was the Extended Access GP scheme, which were a set of additional contracts for the general practitioners to incentivize them to provide after-hours care or treatment for minor injuries, for example, rather than continuing to pursue new options, such as new walk-in centers as an avenue for diversion, which often are useful, but maybe not used to their full capacity. So there's been this focus on improving services that already exist within the community, which really chimes with what we've seen in the Australian context of assuming that people know where to go when something is, or people have certain places in mind. So it's a matter of improving the services available either in community or at hospital to divert individuals to the appropriate avenue for their care. There's also been a large amount of funding announced since 2023 for 110 new urgent treatment centers, which are open 12 hours a day for urgent and same-day medical issues. They can either be accessed through walk-ins or a pre-booked appointment that can be done through the virtual telehealth line. And these were set up as standalone centers, but there have been urgent treatment centers for a long period of time. But these new ones are generally being either co-located with community primary care services or near hospitals, which resonates with some of the work in Australia, that we understand that people know where to expect to go. So it's a matter of providing viable options for appropriate and responsive care that are not necessarily in emergency department triage. Overall, we anticipate there will be further policy announcements about reforms and resources that continue to support the shift from community to from hospital to community-based care, and that but overall, there is really strong pressure as a whole that is unresolved on emergency departments as a whole. There still is, similar to what we saw in South Korea, there is a target for 78% of patients presenting at ED to be seen within 4 hours that was still in place as of January 2025. However, this has been a target that's been criticized on and off for several years since its introduction. So it's an interesting example of a governance mechanism to try and promote appropriate use and pathways of care through the emergency department. So from there, we will turn to Denmark, where, similar to Australia and England, we find that there is quite a bit of another set of structural reforms that were recently approved by the Danish Parliament in November of 2024 that will focus on introducing new integrated care planning and coordination of care for the Danish population as a whole. So there is a new organizational structure that will be looking to do quite a bit of task shifting from municipalities into 4 health regions that will be governed by health councils. This is going to create, this will condense some of the existing, at present there are 5 health regions, which will now be reduced to 4 health regions. One of our key informants wanted to note that one of these health regions will actually be responsible for the health of about half of all of the population. So it'll be really interesting to see how these developments continue to proceed in the coming months and years. Overall, the Danish health system has also has some very interesting policy exemplars in terms of how they address demand for emergency departments. We found that the telephone triage service has been helpful and is still very much in use and mentioned as an important component to supporting the appropriate presentation of individuals requesting urgent care. And there has also been new developments in that the Danish government has seen that there's quite a bit of demand for specialized acute nursing care, which will support role substitution and advanced care planning in emergency departments. So this year they'll be introducing new specialist training that will be available for nurses who want to take on that specialization to improve health systems resilience and staffing for emergency departments. Lastly, we will turn to the Netherlands, which is always a really interesting example about how how demand for emergency care can be managed primarily through a robust primary care network. So in the Netherlands as a whole, we find that care continues to be developed, and demand for emergency services is often delivered through multidisciplinary health networks. A key advantage that I think has been coming up a lot in the news and when we speak about primary care needs is that in the Netherlands, there's really high patient empanelment, with over 95% of the Dutch population registered to a family doctor that is within a very small geographic distance of individuals' homes. This, accompanied by strong workforce regulations and sets of incentives related to out-of-hours care and to continuity of care between providers, is responsible for making sure that most of the Dutch population has access to regular and reliable primary care both during working hours and after working hours. That contributes to quite a low level of what would be considered inappropriate presentation at emergency department. So we find two really interesting policy innovations that I want to highlight in today's presentation about how this is approached in the Netherlands. The first are emergency care access points, which are collaboratives between primary care providers, which are groups of about 70 family physicians who combine their contracts for their after-hours care into a rota for clinics that are located either near or within hospitals. And when people present at them, the primary care providers who work there as part of their part of the minimum after-hours care they have to provide as part of their GP contract is that they conduct triage and treatment for self-referrals, and they then refer appropriate cases on to emergency departments, which helps to promote appropriate and responsive access to care while ensuring that those who present at the emergency department do require the care that is provided at emergency departments. Secondly, we have the Huisartsenposten telemedicine system, which also provides out-of-hours care between 5 p.m. and 8 o'clock a.m. and on weekends and holidays that provides multidisciplinary, that is a telemedicine system staffed by multidisciplinary providers, so it's a telephone triage system, which is then able to dispatch paramedics, nurses to provide advice or to the site of the person requesting support. And they also have access to what are called night pharmacies, which is specifically that they are able to, that these practitioners are able to issue prescriptions that can be filled during non-working hours. We normally have pharmacies based in hospitals, but they are able to promote appropriate and responsive care outside of the emergency department, and there are also other initiatives underway right now to improve the coordination of care between the HAPs and hospitals and long-term care facilities to provide care planning and treatment for older people in long-term care homes who may have acute unplanned issues overnight, for example. And lastly, similar to some of the insights that Husayn mentioned about the use of AI and new technologies, the Dutch Minister of Health mentioned that they see a key role for the use of AI in healthcare and hospitals specifically to be used to streamline patient care and shorten length of stay of patients and to improve clinician collaboration and co-working in emergency departments. So it'll be interesting to watch that space and see how those new technologies are used to streamline and their potential to streamline pathways of care. Last, if I can see, great. I just want to highlight some of the overall limitations of both the academic study and the jurisdictional review. I want to note that, of course, a limitation is that this work is a rapid review that was conducted over 2 short timeframes, one in winter of 2023 and the second about 18 months later. However, we do feel that this does provide an accurate snapshot of current policy options related to emergency medicine at the moment, based on validation with local experts and in consultation with interested and the gray and academic literature. We would like to note that overall, particularly from the first rapid review, we do find that there is a lack of evidence from robust empirical evaluations of emergency diversion reforms. Often we find that research and evaluation are performed on ad hoc basis or during an early piloting stage, and often much of the work we look at does look at interventions on quite a small scale, for example, at the hospital level or with specific tracer conditions or clinical domains. So, there are analytical limitations about our ability to, compare and draw out broad conclusions across different domains due to different access to healthcare resources, capacity, different types of remuneration, and of course, different populations and geographic size. And we do want to note that some of these really promising innovations and initiatives, there may be limitations to their scale in other jurisdictions as well. So with that said, we do want to move to our policy recommendations. Which are we drew on the ones from the initial rapid review, and during the course of this academic and jurisdictional review, we sought to validate and really interrogate whether these are accurate and to deepen our understanding of these. And we've come to these 3-pronged policy recommendations, and we bring general recommendations and specific examples based on the empirical data as we go through them.
Stefanie, just
Yes.
John, and if it's okay, Sara, I just wanted to go, because some people started late, and I wanted to remind them if they did have questions to put them in the Q&A. And so we're going to the particular presentation. But I was wondering whether we might just take a couple of minutes just to address there was a question put in which was related to the other section that just happened, which was from Dr. Dowling, from Sean, and I think they were just quick. One was, given the abundance of literature that suggests low acuity patients do not contribute significantly to ED wait times, what prompted this to be included in the review? And if it was us, it might have been us asking the question. But the contemporary perspective seems to the biggest issue is throughput of the boarded patients getting consultation and admission for that. But just any comment on the low acuity patients and inclusion of that question, given that they weren't seen as a major issue in ED wait times.
Yeah, that's a great question. We really appreciate that. And thanks for the interruption, John. So this came out of consultation with the literature and with policy experts in the various jurisdictions in terms of how they're proceeding to tackle these challenges from a systems perspective. So I think it's as you take a systems perspective to addressing the ED challenges, you have to focus focus squarely on the emergency room. As you mentioned, most of the issues with regard to throughput and where enhancements can be made and leverage different types of health workers and the way they communicate and coordinate their care. But also we can tackle the multitude of challenges outside emergency room and consider the appropriate use of care in the community to address both a gap in primary care and being able to access care when needed. And perhaps more marginally, as you point out, it may not solve the problem of overuse of EDs, but it will improve the care and routine access for people to address chronic disease management and other routine conditions that may have longer term impacts on their health and the reduction of ED use in the long run. So it may not be a short term solution to the challenge. And I fully take the point that it won't really solve the problem right away, but in the long run, it could address more systemic, broader system issues, but also population health challenges.
Yeah. Yeah, and I think you might in the recommendations address Sean's second question, which was about how factoring in the larger healthcare environment and how it's organized, and what are the alternatives that you can refer someone to often, because it's the only place. But I'll just can proceed along with the recommendation section, but just wanted to note to people there is a Q&A function, which we don't have the mic open to people, so it'll just be written in the Q&A if you have a question or comment. Thanks very much.
Thanks, John. And please do add your questions. We'll have some time to address them and have an open dialogue, and John can weigh in and others as they are also experts in this area. But the three broad buckets will be familiar to all of you, especially those who are fans of the World Health Organization's Health Systems Framework, which includes these as three of the essential building blocks of the health system. And so we thought it useful to refer back to those broader concepts, because the evidence coming out of the literature and through the reviews of these jurisdictions that Steph presented, they seem to fit nicely within these three building blocks specifically. And within service delivery, there's sort of a range of different approaches that we've seen, talking about the types of the ways we expand. And, we just talked a lot about expanding access to primary care and ensuring appropriate use, but also innovations to support the sort of pathways of those seeking ED care. And, on the first side, this is, again, that sort of broader system challenges of how do we better care for people with long-term chronic conditions and ensure they're not using the ED because of access problems in the community. And so we've kind of grouped them into a few different options that have come out of the literature in terms of, expanding access, but also ensuring greater attachment to longitudinal care. And the second point within service delivery is sort of about the expanded community-based clinics. And these are where those sort of urgent treatment centers and urgent walk-ins, often located near hospitals or co-located, and the types of virtual EDs and so on can be sort of placed here, where there's a long list of the types of expanded community-based clinics that are helping to alleviate some of the burden from EDs, where people can get better care, more appropriate care for their needs. And then some of the service innovations with regard to the patient pathways can include these types of technologies that we've talked about, but also new ways of leveraging the workforce and optimizing triage processes specifically. So we've sort of grouped a lot of these options within a kind of service innovation bucket, and a lot of activities seem to be placed here. And most of the literature, I guess, kind of falls within this broader service delivery building block. But we did also find some, focus on governance and leadership, and the kind of the ways that we're changing the sort of overall guidelines and policies affecting care delivery, and the use of targets, for example, to set clear goals for what should be achieved and what could be expected and communicated to the public, but also sort of changing the way different providers work together, and the tools that are in place to support coordination. So this really does require some oversight and kind of changing the way that providers normally work, versus sort of addressing these care delivery, more immediate, more sort of close to the patient care innovations that we've seen. But the third broad bucket is about the workforce specifically, and broadly around the kind of role substitution that we talked about, and the new ways of empowering and training workers to sort of fill in some of those roles, and allow for new career pathways to enable role substitution, as well as workforce training and to support the complex populations that are appearing in emergency rooms, and sort of new advanced practice roles as well, and how and facilitating their involvement within the ED to manage within emergency rooms themselves. And social workers also appear as well as physician assistants and other extender roles. So we've kind of bucketed them here. This is like a long menu of options that we've seen and we've compiled, and we think that hold promise by taking a sort of systems approach and looking at all three aspects of the system concurrently. So we have lots of time for questions. We'll just conclude with a few points around, we think there's always opportunities to learn, both across provinces in Canada, but also across countries, especially as different countries face the same policy challenges. And, we obviously need to adapt some of these solutions to our own context, but we think there's opportunities here in this type of comparative research. And, we've seen innovations across service delivery, across governance and leadership, and across health workforce. And probably the most promising way forward is to address the problem from all three angles and to study those, because as Steph mentioned, much of the research that we've been able to rely on is pretty minimal in terms of the time periods being covered and the rigor of the evaluations. And many of the interventions we presented are also just too recent to have much evidence base yet, but the colleagues that we spoke to around in these countries are working on and getting those evaluations underway. So we look forward to hearing your questions and comments, and thanks again for the opportunity.
Thank you so much, Stefanie and Sara and Husayn, for a great presentation and for your ongoing work in this area. I will note, because Brian Rowe had provided another kind of comment, which I think echoes Sean's, which was around because the definition of diversion bothers him a bit, he kind of said, and I think Sean echoed it too, in terms of, I think, a focus for a lot of policymaker and politicians. So we just need to divert all these people away from emergency rooms who are low acuity. And I have heard this too from people who work. It's not the low acuity that we worry about. We worry about the severely ill who don't actually get care and could decompensate in an emergency room waiting, and they can't get up into a medical bed and that kind of thing. But he did highlight an article which is addressing the low acuity patients. Is the juice worth the squeeze? I think that's actually a great title. But just commenting on the fact of his perception, and certainly Brian's a real expert in the emergency services area, evidence regarding the impact of diversion strategies generally in terms of major primary focus. But Stefanie, I don't know, or Sara, if you had any particular kind of comments in response to the whole issue of a diversion as a major component of addressing the ED backlog problem.
I think this group of attendees know more about the evidence base than we do. We were driven in part by the sort of policy priorities of the jurisdictions, and I think I hear you guys. I think that the taking this long-term view, perhaps it's less expensive to manage and to kind of frame it in this way, and so maybe doesn't tackle some of the bigger issues within emergency rooms. But it's right. Interesting that across all these jurisdictions, there is a bit of a framing of the problem that is quite consistent and perhaps disconnected with the needs and priorities of people providing the care in emergency rooms. And so it'd be interesting to try and bridge that gap. And we can try and do that on our end to some extent, and we appreciate this feedback.
Yeah.
Yeah, and I would add to echo what Sara said. I think that we took a real health systems approach in terms of what can we do to expand access, and I think that there was that focus on primary and community care that was really led by the jurisdictions that we were seeing. But I do think that many of comments are very valid, and I've just saw Sean's comment about how many of these solutions are in place in Alberta, and we'd be really interested to follow that up and understand which of these policy options we present are in place in different areas, what the evidence is around how well some of them work. But with that said, I do think that a lot of some of the really innovative and interesting work that we did see from different parts of the world, I found it very interesting to speak with local experts about different initiatives, particularly around ambulatory conveyance and the upskilling of paramedics and the use of multidisciplinary teams, particularly to make sure that you don't end up with that bed blockage and that issue of patients in ED waiting to be admitted into hospital, and that or back into long-term care, or where there are viable options for them to be boarded. So that, I think, is a piece of the puzzle that perhaps we could have put more focus on in future dissemination that is in the research.
Yeah, and I think it's great to be able to have it is a complicated system in various parts of the pie to expand on. Particularly, Sherry echoes a bit of the similar thing about the undifferentiated patient coming into the ED, and that being a concern in terms of the pathways that might provide it. And I have heard actually that often a big difference between coming in an ambulance and walking through the door, and what are the different kind of pathways that might move forward, and the unique characteristics that take place in an emergency room in terms of processes that might be done there for efficiency, but also sometimes you're waiting for a bed that is not available in an overcapacity hospital, so you can't move them out of that situation. Yeah, and Sean just noted that Alberta has a very high non-conveyance rate through that. Is there any, Brian does note about Health Canada doesn't provide leadership to resolve ED crowding like the NHS has. And maybe any thoughts from how might Canada deal with recommendations in light of our federated system, and anything that the levers that might be provided federally? I know they've done some emphasis particular around elective surgery wait times often is a priority, or investments in primary care. But I don't know if any of the team have some comments in response to Health Canada leadership in this particular area.
Yeah, and I think the main gap in sort of knowledge that Health Canada can help fill is through their funding of CIHI and better reporting the data that we have that's comparable across the country. So they've invested a lot in the data space, and so there's huge gaps there and huge amount of inconsistency in the way that we capture data on emergency departments, on these measures of throughput, and on issues around wait times as well, where I think the focus has been more on elective because that's where you can measure. But I think that's Health Canada. It's fully within their purview. They can invest more on the data side and on research, because they also fund health research. So they could have dedicated funds for research on emergency rooms specifically, and funding the long-term policy impact studies that provincial governments don't seem to be investing as much in. And that kind of relates to Deborah's comment around which countries have in place these evaluation and performance indicators, and they are there to quite a, I would say more advanced than in Canada, in all the countries we looked at. And it's interesting, for example, in Australia, which is also a federation, the federal government plays a much bigger role in healthcare in Australia than in Canada, but still it's shared with the states, and hospitals are under state jurisdiction and doctors are under the federal jurisdiction. So that raises different challenges. But what they've done is to fund, so invest in urgent care clinics, as Steph presented, negotiate somehow how that's going to complement the existing state level investments in urgent care clinics and not duplicate and further fragment and raise inefficiencies. So dealing with the coordination of the state level initiatives and state run and funded hospitals, while at the same time investing in a massive research and evaluation program to study the impact of these urgent care clinics. So our colleagues have, applied for that funding to do a long-term evaluation, process evaluation, and outcome. And this relies on data being available and linked and shared. And to some extent, it is available, but jurisdictional issues and boundaries do complicate it in Australia as well. So that's just one example of how Australia has navigated it and the investment that's needed for research. And I think, that's where Health Canada could step in.
Right. Is there much, and I know there was the use of AI. This was just one quick question because there was some other work that I kind of was involved in terms of point of care technology in regards to point of care testing, diagnostics that can be used now, where patients are delayed in EDs and stuff, waiting for some diagnostic protocol. Because I know there's a bunch of things where things are now being able to be brought to the bedside, or quick tests are able to be done point of care that don't allow that diagnostic delay. I was just wondering about any thoughts, or maybe that could be some future work trying to be done, but the diagnostic delay where people are waiting for something that might be done more rapidly. I don't know if that came up in the work that you were doing.
Yeah, I think that came up as a current sort of priority is investing in these tools because they seem to be at least holding promise in addressing some of those waits. But I haven't seen any evaluations, and I think this would be an interesting follow-up study in terms of the use of technology, the use of digital tools, but also AI specifically. I know colleagues in Ontario have used and are actively using and testing AI within hospitals in Toronto and dealing with facilitating the kind of predictions and planning care pathways in internal medicine, for example, but we haven't included it in our review, and we actually didn't see a lot. I don't know, Husayn, if you have anything to add from the academic literature, but it's a bit more emerging than what our time period covered. But
also just a thing, because I know it's really come up recently across health systems generally, is health workforce. And I didn't know whether in the study in talking about making sure that emergency care is attractive, right, for people to be able to staff up and deal with both nursing and physician care, because I know that's becoming an increasing challenge. And it goes in ebbs and flows. Sometimes people like to be able to do a shift and be able to be predictable and not necessarily run a kind of their own personal practice, but to be able to go and practice emergency medicine. But were there any kind of workforce observations or things actually in terms of that staffing and capacity building for people who can work in those particular settings?
Not as a major theme, but it did come up in the sort of workforce-related policy interventions as an area of focus for just different jurisdictions, where I didn't see anything specific about like seats or residency opportunities for emergency medicine or remuneration, but it seems like a separate sort of question is to ask how different jurisdictions are incentivizing and promoting the recruitment and retention of the workforce within emergency rooms, and because it surprisingly wasn't a major theme in our reviews, but I mean, that's a really good question and something to consider.
I do want to, because there was a comment from Mark too. Our original report is posted on our website, and it links to the NAO report. The second report you did for Healthcare Excellence Canada, it is now complete and it's posted on your website. Correct, Sara?
Yes, and we're happy to share the link around as well.
And I'll post both up on the IG website, and certainly we'll post it on the NOAA website, and a recording of this will be posted along with the PowerPoint slides moving forward. So people will be able to have that information. And I think there's going to be some ongoing work, and hopefully email us if you want a specific copy of the study now, but can certainly do that. So I just want to say, because we only have a couple minutes, of thanks very much for the presentation and for participation with our longtime and great colleagues from the North American Observatory, and thanks for everyone online for attending and your thoughtful questions. The next seminar as part of this series is going to be on March 19th. And it's economic evaluations of interventions in children with neurodevelopmental disorders. And that's Dr. Sean Gia and Dr. Jennifer Zwicker. And that's on March 19th. And please visit the NOAA website for any upcoming sessions. And we will be posting the presentation and the webinar and the documents. So and Stefanie just put the link in the Q&A if you want for the 2023 report, and so people can look at that. But thanks very much for attending, and great discussion and great questions, and everyone have a good rest of the day.
Thank you. Bye.